I would love for us to just be a little open-minded and consider that patient is more than just the tendons on the radial side of the upper extremity, of the lower portion of the upper extremity. So from anatomy trains, we see the thenar eminence being associated with the biceps brachii, as well as the coracoid process. That's attaching fascially to the pectoralis minor. So again, when we're looking at the thumb, I want us to come up the kinetic chain through the biceps and into pec minor and realize that fascia being restricted anywhere along that line could possibly play a part with our person having this thumb problem. This train that we're demonstrating or talking about now has been further substantiated by Robert Schlipp in his textbook Fascia. In our module 2, we talk a little bit of something called the dynamins theory. I love this concept. This gentleman by the name of Van der Waal is the one that talks about it the most if you do a search of him in the literature. He talks about the force not just being transmitted into a lone structure like a muscle, but that force is also transmitted along muscles in series, and not just along the muscles in series, but into the surrounding tendinoperiosteal structures and ligaments as well. And I think that that's something that we can take a look at when we're working with our patients who have DeQuervains. So I'm just hoping that we would consider the various positions that our patients may be in that's then put. As I go to do that, I do want to give a quick tip of the hat over to our colleagues at functionalmovement.com and their functional movement assessment, their SFMA. We've taken some of their larger concepts. And so in this particular slide, what you're looking at is full body rotation. So, hey, patient, can you stand, feet together? And I want you to rotate to eventually each direction, okay? And as the clinician looking at the patient, what I'm looking for is, can that patient rotate through their pelvis at least 50 degrees? Do I get an additional 50 degrees of rotation in the trunk shoulder region? And can I get that rotation with no spinal or pelvic deviation? So, you ask a patient to rotate and they're all trying to bend, or, just rotation. No spinal or pelvic deviation, no excessive knee flexion. Okay. So if I look at the patient and they do not rotate at least 50 degrees in the pelvis, or they do not rotate at least 50 degrees in the trunk, then I want to break down those parts of that larger movement and say, where are you not moving well? And are you not moving well because you have a joint mobility or a tissue extensibility problem?